So all three groups, government, individuals, and employers, are all saying the same thing. It costs too damn much. And it's going up too damn fast. And we are all going to be held accountable to the same standard, and that's going to be healthcare cost trends going forward that look a darn much more like CPI. Not 7, 8, 9, 10, 11% year-over-year increases. Those days are gone. Those days are gone.
So picture Saul on the road to Damascus gets hit by the bolt of blinding light. That was my epiphanous moment when I understood that this healthcare transformation is for real. Now that the employers are driving this forward, it's no longer coming out of a policy think tank, government, which can get pushback from lobbyists. Corporations do not mess around. They've got a quarter mistake to it. So I said, oh my God, this is serious. Okay.
Before I get there, I would like to just sort of level set expectations about this whole issue of payment reform and what it means. So the important thing to remember with all of these new payment models is that this is not a free ride. It's not a free ride for primary care, it will be a free ride for specialists. I think it's wonderful to have a whole bunch of shared savings models, but if you don't have the infrastructure, the tools, and more importantly, the transformational processes inside of your practice to take advantage of the tools, you'll never reach the goals, and you'll never share in anything.
In order to convince our employers and employers who have patients that come to you, they wanted to know the bottom line. Does this patient-centered medical home process really work? And from our numbers, just the Anthem patient population, we found a 2.5 to 4.5 to 1 ROI. So we really believe this works.
The implication there is that not all specialists, number one, were asked to play, and not all those that were asked chose to play. So I think that there's a message here that I think that specialists in these types of models obviously have to decide, do the analytics inside of their own practices as to whether or not these types of arrangements make sense.
Our ecosystem is no longer tolerate care being delivered by disconnected, fragmented small practices. We're going to have to leverage the power of these health information technologies. You're going to have to know your own metrics. And secondarily, you're going to have to communicate those back into a larger system. So if you've been holding off on electronic records, it's time to get serious on that discussion.
You may not know, but Medicaid in Colorado is 85% fee-for-service, which means we totally pay into that broken system of paying for sick care, paying for volume. And what we really want to do is change how we're paying so that we're rewarding health, we're helping you keep people healthy, and do the things you want to do in your practice. So our effort to transform Medicaid into the delivery system is called the ACC, the Accountable Care Collaborative. It's really meant to be the foundation of our delivery system. If healthcare expansion in Medicaid happens, certainly those people will be put into the ACC model. And it's not fee-for-service, it's not traditional managed care, it's sort of a hybrid model. I think we've found, as the pendulum swings, that there are problems on both sides, so we're kind of trying this middle approach.
We have to identify who are those physician partners in the community that we can actually talk about value-based contracting based on population-based metrics. So I think you're going to hear a theme amongst all of us that no more is it just a productivity RV model. That will always be there, but it's going to transform to say, what are the quality indicators in your population that we can start holding you at risk for? can we work with a more narrow group of physicians and actually interoperatively connect? The real goal with healthcare reform is all the data for all the patients all the time. So what I would advise you in terms of first steps, I think you're going to have critical mass. I think you're going to have to be at least with other physicians that you can at least have a sample size of patients that you can actually begin to look at them as a population. And then you're going to have to work with one of us up here at this table, or people that we work with will know. You're going to have to work with us and say, what are some population-based measures that we can at least begin collecting information on?